Good morning. I am Dr. Chari Herrera Manlangit, your lecturer for today. I am not a pediatric infectious specialist, but rather a pediatric pulmonologist. Likewise, I am not a representative of the Center for Disease Control. Today, I'm going to start my lecture with the Zika virus infection, which has been or has been an emerging public health concern. Zika virus was first isolated in April 1947 from a rhesus macaque monkey that had been placed in a cage in the Zika forest of Uganda near Lake Victoria by the scientists of the Yellow Fever Research Institute. A second isolation was done from the mosquito Aedes africanus, followed at the same site in January 1948. When the monkey developed a fever, researchers isolated from its serum a transmissible agent that was first described as the Zika virus in 1952. Primarily, Zika virus infection is an arboviral infection. This is through the bite of an infected Aedes aegypti or Aedes albopictus mosquito. Many people won't have symptoms or will only have mild symptoms. Infection during pregnancy can cause microcephaly and other severe brain defects. Zika virus is a member of the Flaviviridae family and the Flavivirus genus, and this is transmitted by the daytime active Aedes mosquito, particularly the Aedes aegypti. What is Zika virus? This is an RNA virus which contains around 10,794 nucleotides encoding 3,419 amino acids. It is closely related to the Spondweni virus. And the two viruses are the only members of their clade within the mosquito-borne cluster of flaviviruses. Now, Zika virus has been reported in many countries. The Zika virus disease outbreaks were reported for the first time from the Pacific in 2007 and in 2013, and in 2015 from the Americas involving Brazil and Colombia, and Africa. More than 13 countries in the Americas have reported sporadic Zika virus infections, indicating rapid geographic expansion of the virus. What about the Philippines? It was the first case was detected in the 15-year-old boy infected in 2012, wherein he recovered after 3 weeks. There was another report in March 2016, which was an American woman infected with the virus while visiting and stayed in the Philippines for 4 weeks last January 2016. How is this transmitted? Now, the Zika virus is transmitted to people through the bite of an infected mosquito, as mentioned, from the Aedes genus, mainly the Aedes aegypti in the tropical regions. This is the same mosquito which is responsible for dengue fever, chikungunya, and the yellow fever. Now, Zika virus is transmitted by these daytime active mosquitoes and has been isolated from a number of species of the genus Aedes, such as your Aedes aegypti, Aedes africanus, and other arboreal mosquitoes. Studies have shown that the extrinsic incubation period in the mosquitoes is about 10 days. However, transmission from mother to child is rare. There was a study that a mother already infected with Zika virus near the time of delivery can pass on the virus to her newborn around the time of birth. But again, this is rare. It is also possible that the Zika virus could be passed transplacentally from the mother to the fetus during pregnancy. However, this mode of transmission is still being investigated. To date, there are no reports of infants getting Zika virus through breastfeeding. Because of the benefits of breastfeeding, mothers are encouraged to breastfeed even in areas where the virus is found. Zika can migrate between humans. It's either through sexual contact or through the placenta, affecting the unborn fetus. The mother already infected with the Zika virus near the time of delivery can pass on the virus to her newborn at the time of birth. Other modes of transmission would include blood transfusion and sexual contact. So what are the symptoms of this Zika virus infection? Zika virus remains in the blood of an infected person for about a week, but it can be found longer in some people. These patients may have fever, rash, joint pain, or conjunctivitis. Others may have muscle pain and headache. If a pregnant woman develops the above symptoms within 2 weeks after traveling to an area with Zika, then you will suspect that this could be a Zika virus infection. These symptoms would last for several days to about a week and remains in the blood of an infected person for about also a week. So who gets Zika virus infection? Those who have traveled to affected tropical areas and have been bitten by a mosquito that carries the infection. It has been estimated that only about 1 in 5 people carrying the virus actually develop symptoms from the Zika virus infection. In New Zealand, there has not been any known Zika virus carrying mosquito, and to date, Zika virus infection there has only been reported in people that have been recently traveling to an affected area. Around in 2014 to 2016, the infection has been found in the Pacific Islands, Southeast Asia, Central and South American countries. So, what are the complications of this virus? Patients may have Guillain-Barré syndrome. This is a rare, rapid onset form of paralysis. It is also an autoimmune syndrome and is often associated by an infection a few days to weeks earlier. The first case of Zika virus infection complicated by the GBS was reported from a French Polynesia in March 2014. And there were also other cases found in Brazil. However, death is rare. So, the risk of Zika virus infection damaging a fetus is unknown. So, what happens to these fetus? In Brazil, it has been reported to increase birth defects in babies born during the recent Zika virus epidemic, wherein they have fetal microcephaly, or what you call as the children will appear or having a small head. That's why it's called microcephaly. So if this here is a normal head size of the baby, then when they come out after delivery, they would appear to be microcephalic, or the head size will be smaller than the expected normal head size. So this could be measured through the head circumference. And there may also be intracranial calcifications or this will be the calcium deposits in the brain. So how is testing done for Zika virus? So pregnant mothers with suspected Zika infection or those who have recently traveled to an infected zone should see their doctor or midwife to undergo testing for this virus. Now, the CDC recommends a serial ultrasound examination to monitor fetal growth and anatomy. And they also recommended referral to a maternal fetal medicine or infectious disease specialist with expertise in pregnancy management. Amniocentesis can also be done or may be considered after 15 weeks of gestation. Some molecular and serologic testing of infants who are being evaluated for evidence of congenital Zika virus infection is also been done. However, there's no commercial tests for Zika virus that is available. Zika virus testing is performed at the CDC and some state and territorial health departments. So it is only there that we can do these testings. So the Zika virus infection classification and considerations. So the diagnosis of Zika virus infection is made through molecular and serologic testing. What are these? Now we do know or we are familiar nowadays with this COVID time about the reverse transcription polymerase chain reaction for viral RNA, or this is the RT-PCR, and the immunoglobulin or the IgM ELISA, and plaque reduction neutralization test or the PRNT for the Zika virus infection or Zika virus antibodies. So, as mentioned, these children affected with coming out from the mothers infected with Zika virus, they appear microcephalic, and this has been a great concern. So, again, the symptoms it would include below average head size, and this is often caused by failure of the brain to grow at a normal rate. So normally, in this, when you measure the head circumference, they would be microcephalic if the head circumference is less than 31.5 to 32 centimeters at birth. And in the US, there are 25,000 children who are affected by this microcephaly. Now, Zika virus testing is recommended for those infants with microcephaly or intracranial calcifications born to women who traveled to or resided in an area with Zika virus transmission while pregnant, or for those infants born to mothers with positive or inconclusive test results for Zika virus infection, and also for those infants with laboratory evidence of a possible congenital Zika infection. Clinical evaluation and follow-up is recommended. For healthcare providers, they should contact their state or territorial health department to facilitate these testings. So what about the management and prevention? So there's no specific antiviral treatment available for Zika virus infections. Likewise, there's no vaccine. And the treatment for congenital virus infection is mainly supportive, meaning the management should be addressed to specific medical and neurodevelopmental issues for the infant's particular needs. It has been encouraged, or breastfeeding has been encouraged for mothers infected with these virus. Okay, so we still continue to breastfeed the infants even in areas where the Zika virus is found, as available evidence indicates the benefits of breastfeeding outweighs the theoretical risks associated with the infection transmission through the breast milk. So what about prevention? It has been said that the only way to prevent congenital Zika virus infection is to prevent maternal infection, either by avoiding areas where the Zika virus transmission is ongoing or strictly following steps to avoid mosquito bites. So how is mosquito bite prevented? So using air conditioning or window and door screens when indoors, wearing long sleeves and pants, or by using insect repellents. So what should you do? People should make every effort to eradicate mosquitoes from their living and working environment to avoid being bitten by mosquitoes. So it's the same prevention as to the dengue, dengue infection, like we do cleaning up of our backyards, here emptying standing water from containers around the house, which could be a breeding grounds for mosquitoes. And also applying mosquito repellents or wearing some long sleeve shirts. And for since this is can also be transmitted through sexual contact, then the use of condom is highly encouraged. So again, there is no vaccine that is available to prevent the infection or to treat this Zika, and prevention is the only available option. So, to summarize this Zika virus infection, this is transmitted by a mosquito. About 1 in 5 people infected will become ill or become symptomatic, wherein symptoms normally last around 2 to 7 days. And the illness is usually mild and death is rare. Symptoms would include fever, rash, joint pains, conjunctivitis. And there is no treatment or vaccine that is available. Okay, so we shall move on to the next infection, to the next virus. So if you could see this, a man with very puffy eyelids, an edematous face, the lips are so edematous as well. So what do you think is happening to this patient? What infection is this? So this is another public health emergency of international concern, the Ebola virus disease. Ebola virus is also known as a viral hemorrhagic fever, which is a group of illnesses caused by several distinct families of viruses. In general, the term viral hemorrhagic fever is used to describe a severe multi-system syndrome. Characteristically, the overall vascular system is damaged and the body's ability to regulate itself is impaired. The virus is an arena virus, filoviruses, and bunyaviruses. No, these are all RNA virus. Okay, which is the survival is dependent on animal or the insect host, or which is now your natural reservoir. And in this case, this is a flavivirus. The humans infected are the natural hosts when in contact with, the humans get infected when they come in contact with the infected hosts. Okay? So geographically, this is restricted to areas where the host species live. And there are human cases or outbreaks that have occurred sporadically and irregularly. With few, there is no cure or established drug treatment. So where does the Ebola belong? So this belongs to the family Filoviridae, which also includes your Marburg virus and the Ebola virus. Okay, so this has been discovered in Congo, Democratic Republic of Congo in 1976. So there are five subspecies, and only four of these would cause disease in humans. This includes your Ebola virus, the Sudan virus, and the Bundibugyo virus. And the fourth one is the Thai forest virus, which is formerly the Cotilliv virus. Natural reservoir that is unknown. However, it is believed to be zoonotic or animal-borne, with the bats being most likely the reservoir of this virus. The fifth subspecies would be the Reston Ebola virus, which have caused disease in non-human primates. And this has been isolated from infected cynomolgus monkeys imported to the US and Italy from the Philippines. And there were several workers in the Philippines and in the United States holding facility outbreaks which who became infected with the virus. However, they did not become ill. So the 2014 West Africa outbreak, this was the largest Ebola outbreak in history. The first known outbreak was in West Africa, and this was the first Ebola epidemic the world has ever known. This, as of September 29, 2014, there were like 6,574 cases, 3,000 of which were the total deaths recorded. The transmission is that the first patient becomes infected through contact with an infected um, host, no? So the human-to-human transmission was also reported through direct contact with blood or secretions of an infected person. Likewise, there were also reports of exposure to objects such as needles among healthcare workers that had have been contaminated with infected secretions. And the incubation period is around 2 to 21 days after exposure to Ebola virus, with an average of 8 to 10 days. So what are the manifestations, or how are the patients presenting symptoms? So patients may have fever, headache, joint and muscle aches. They may have weakness, just like any flu or any or sore throat. So if you compare this to any viral infection, like for now the COVID infection, so these manifestations are almost all the same. However, in this Ebola virus, there's a hemorrhagic rash that would appear over the entire body. So some may also have diarrhea, vomiting, and also symptoms of impaired kidney and liver function. For severe cases, patients may also be bleeding. So, for the diagnosis, what are the diagnostic tests available? So if you have within a few days after symptoms begin, you can either get your antigen capture ELISA or the IgM ELISA. You can do PCR testing or virus isolation. If the disease or if the patient came in with in the later course of the disease, now you could, or after recovery, then you could do your antibody testing, which is shown by your IgM or your IgG. Okay, so retrospectively in diseased patients, you can also do immunohistochemistry, PCR, and virus isolation. So again, management is supportive. Either you do rehydration through IVs, IV fluids, or oral fluid intakes, and symptomatic treatment. There's still no licensed treatment proven to neutralize the virus, and there's no licensed Ebola vaccines. However, there are two potential candidates undergoing investigation. So, what is the prognosis of this virus? The average EVD case fatality rate is around 50%. And how there were, and that's the average 50%. And the range would be around 25 to 90% in the past outbreaks. So, again, how do you prevent this infection? So, the aim is to avoid contact with the blood or secretions of an infected person. Okay? So, healthcare workers should always take standard precautions when caring for patients, regardless of their presumed diagnosis. And this would include basic hand hygiene, respiratory hygiene, use of PPEs or your personal protective equipment, safe injection practices, and safe burial practices. Okay, so when in close contact, meaning you are in the close contact would be around 1 meter from that infected person. Um, the healthcare workers should wear face protection, such as your face shield or medical mask or goggles, and a clean, non-sterile long-sleeved gown and gloves. Sterile gloves for that matter. Okay? So, how do we control the outbreak? It is collaborative effort through community engagement. So there should be package of interventions such as case management, surveillance, such as contact tracing, good laboratory service, safe burials, and social mobilization. So this is the recommendation of the WHO. How about in the local setting? So Philippines DOH is in collaboration with the DOLE or the Department of Labor and Employment, the Department of Foreign Affairs of your DFA and other agencies. Also, we are in collaboration with the RITM or this is the hospital or the where we send our testing centers in Manila. However, this is in the case of Ebola, okay? But in for now in COVID, then we already have a lot of testing centers. So preparedness and response to EVD, there is an interim guideline on prevention and control of the Ebola virus disease. So just an overview of the case definitions. Okay, you're familiar with these terms. You have your PUI, you have your person under investigation. This is a person arriving in the Philippines with history of travel within the past 21 days or residents in an Ebola virus disease outbreak affected countries such as Liberia, Guinea, Sierra Leone, and Nigeria. A suspect case is any PUI who develops signs and symptoms during the 21-day quarantine period. And any person with acute onset of fever with at least any three of the following. So you may have headache, vomiting, and with epidemiologic risk factors within the past 21 days from symptom onset. Okay, the other symptoms were already discussed earlier on. Okay, you have also a probable case and a laboratory confirmed case. So what about travel health notices? Okay, so travel notices are designed to inform travelers and clinicians about current health issues related to specific destinations. These issues may arise from disease outbreaks, special events or gatherings, and natural disasters or other conditions that may affect travelers' health. Okay, so we have the watch level 1, wherein we practice the usual precautions. For alert level 2, then it is already the enhanced precautions. And the level 3 is we really have to avoid non-essential travel. Okay, so that's already the level 3. So here you have this tabulation will show you the different levels and the travel action. We already discussed this, or we have mentioned this, and the risk of the traveler. Okay, so if you have level 3, it is already high risk of the travels. Okay, so like increased level 2, wherein you have to have enhanced precautions. Yeah, there's an increased risk in defined settings or associated with specific risk factors. Okay, so what are the facts about Ebola? So you cannot get Ebola through water, you cannot get Ebola through food, nor can't get Ebola through the air. Okay, so to just give you an update, the Democratic Republic of Congo declared their 10th outbreak of Ebola in 40 years on August 1, 2018. The outbreak is centered in the northeast of the country. Okay? And on June 11, 2019, Uganda announced that 3 people had been positively diagnosed with Ebola, which was the first cross-border case since the outbreak began. So there are some few um, cases that comes out. Okay, so we have still to be careful. So let's move on. What is this? You could see camel, and you see here familiar situation that we have now. The people riding in the bus or in the train wearing masks. Okay, so this is the MERS-CoV infection. Okay, so what is MERS-CoV or MERS-CoV? So this is a coronavirus which cause a variety of illnesses from the common cold to our SARS or the severe acute respiratory syndrome, which has also been a global epidemic in 2003. Okay, so to give you a biochemical structure of the coronavirus, so here you have the glycoprotein spikes, okay? So this is the receptor binding and fusion, where the cell fuses, okay? And this is the most antigenic. And here, this is the membrane glycoprotein, okay? It has a triple membrane spanning. And this is here the nucleocapsid, okay, so or a phosphoprotein, which is an RNA binding, here the red ones, the round ones, which is an RNA binding for synthesis, translation, and it is also an interferon 1 antagonist. Okay, so here if you could see these structures, the purple ones, this is a small envelope glycoprotein, and this serves as an ion channel. Okay, and this one is the RNA or the ssRNA in particular. Okay, and here this one, the dark green, is the envelope, which is bilipid and this host derived membrane. So how did this came about, this MERS-CoV? The first case known was from a 60-year-old male from Jeddah, Saudi Arabia, who came in with acute pneumonia with renal failure and who eventually died. So this was reported in June 2012. And the second case was in September of the same year from a 49-year-old female in Qatar with similar flu symptoms. And in the same year, still in the same year, in November, there were similar cases found in Qatar and Saudi Arabia. So, there were various names coming in for this virus. However, it was the novel coronavirus or your nCoV, which was most often used. And finally, they named Middle East Respiratory Syndrome since this is where it was originally discovered. Hence, it's called now the MERS-CoV or your Middle East Respiratory Syndrome coronavirus by the Coronavirus Study Group of International Committee on Taxonomy of Viruses. So, we don't know for certain where the virus came from. However, it likely came from an animal source. So, in addition to humans, the MERS-CoV has been found in camels in Qatar, Oman, Egypt, and Saudi Arabia, and a bat in Saudi Arabia. Camels in several other countries have also tested positive for antibodies to MERS-CoV, indicating that the camels were previously infected with this virus or closely related viruses. Okay, so it may be that people became infected after contact with the camels or more, although there were more information needed to figure out the possible role of the camels, bats, and other animals in the transmission of this MERS-CoV. Okay, so we have to be very careful with also. They may be nice to ride in camels, but they could also be a source of former SCOV. So, how is this infection um, being, brought about or the process? So, there is what you call the eutropism, wherein there is a non-ciliated bronchial epithelial cells, which is unique in the most respiratory viruses, targeted ciliated cells. So here you could see the cilia, okay, in this respiratory virus, okay? So effectively, they evade innate immune responses and antagonize interferon production in these cells. So how is the transmission? So how is this transmitted? Okay, so it is not certain whether infections are a result of a single zoonotic event with a subsequent human-to-human transmission or multiple zoonotic events from a common unknown source. So it has been also known that there's possible close person-to-person contact. However, there's no evidence of sustained human-to-human transmission in the community. So how is it contagious? 75% of recently reported cases appear to be secondary cases. Okay? So in April 24, 2014, the WHO statement, they said that secondary cases or those people or individuals who acquired the infection from another infected person. They are termed these secondary cases. And then when human-to-human transmission occurred, this transmission was not sustained. Okay? So there has been no increase in the size or number of observed household clusters. And the recently exported cases to Greece, Malaysia, Philippines, and the USA have not resulted in onward transmission to persons in close contact with these cases on the airplanes or in the respective countries outside the Middle East. Okay, so that's it. So where are these cases found in the world? So there were countries with laboratory confirmed MERS cases, mostly in the Arabian Peninsula, particularly the Saudi Arabia. Okay, so countries with travel associated were found in these cases, and this includes the Philippines and other Asian countries such as Malaysia. Okay, so in According to WHO, between September 2012 to July 23, 2014, there were 837 laboratory confirmed cases originating from the Arabian Peninsula, wherein 291 deaths were reported. So how are these clinical manifestations? What are these? Um, the incubation period is around 2 to 14 days. Okay, so patients may present with fever, cough, shortness of breath. Secondary cases tend to present with a milder disease than the primary cases. Okay, so they may be asymptomatic as well, but tested positive for MERS-CoV. Who are at risk? So gender-wise, more of females overall, 65.6%. The age group is there's a very wide range between 9 months to 94 years old with a median age of around 49 years old. And who are at risk for severe disease? Those with diabetes, renal failure, chronic lung disease, and immunocompromised persons or any comorbidities. So how are these patients worked up? So again, now here comes your PUI or your persons under investigation. So for people or individuals with fever and pneumonia or acute respiratory distress syndrome based on either clinical or radiologic diagnosis, and either first history of travel from countries in or near Arabian Peninsula within 14 days before onset of symptoms, or those in close contact with a symptomatic traveler who developed fever and acute respiratory illness within 14 days after traveling still to the Arabian Peninsula. Also, fever for those who have fever and pneumonia with ARDS and is a member of a cluster of patients with severe acute respiratory illness of unknown etiology, in which MERS-CoV is still being evaluated. Okay? So any person having fever with symptoms of respiratory illness and being in a healthcare facility or a healthcare worker, may they be a patient, a visitor in the hospital, or a worker in that hospital within 14 days before symptom onset in a country or territory in or near the Arabian Peninsula in which recent healthcare associated MERS cases has been identified. So here, case definitions, you have your probable case. So any three combination of clinical, epidemiologic, and laboratory criteria can define a probable case. Okay, so they may have the symptoms either with clinical, radiologic, or histologic evidence of pulmonary parenchymal disease. Okay, and testing for MERS-CoV is unavailable, or a negative on a single inadequate specimen, and the person has direct epidemiologic link with a confirmed MERS-CoV case. So, who are these? Meaning they are in close physical contact, they work in close proximity, they travel together, or they live in the same household. Probable case number 2, a person with febrile acute respiratory illness with any of the symptoms above and a resident or of a traveler to the Middle Eastern countries where MERS-CoV is believed to be circulating in the 14 days before onset. And an inconclusive MERS-CoV laboratory test. Third probable case, a person with an acute febrile respiratory illness of any severity. Okay, so there's 3 inconclusive tests: a positive screening test without further confirmation, such as testing positive on a single PCR target, and a serologic assay considered positive by the testing laboratory. So, confirmed case is any person with laboratory confirmation in MERS-CoV infection, irrespective of clinical signs and symptoms. So, usually a case can be confirmed by demonstration of seroconversion in two samples, ideally taken 14 days apart by a screening or ELISA and a neutralization assay. Okay, so the presence of a viral nucleic acid can be confirmed by either a positive RT-PCR result on at least two specific genomic targets or a single positive target with sequencing of a second target. So there may also be asymptomatic cases. So the demonstration of a symptomatic infection is useful for epidemiologic investigations. Okay. So due to risk misclassification because of false positive tests due to laboratory contamination, there is an additional step to reconfirm asymptomatic cases or any case in which the diagnosis is suspect. They could include a re-extraction of the RNA from the original clinical specimen and testing for different virus target genes, ideally in an independent laboratory. So management-wise, at this time, all treatment is still supportive. There are no antiviral drug therapy that is recommended, and there is no vaccine available. Prognosis, case fatality rate is around 30%, and the there is a mortality of around 35%. Excuse me. I'm sorry. How about in the Philippines? First Filipina, who died from MERS-CoV, worked in a hospital in Saudi Arabia, Riyadh. She was admitted August 12, 2013 due to a fish bone which was stuck in her throat and discharged 2 days later. However, 5 days after discharge, the that Filipina, developed fever, coughing, and progress, which was progressive. And eventually, she had respiratory distress and ventilated and passed away last August 29, 2013. So the course was really fast. So how do you control the infection? So if for inpatient, the same, we have your standard contact and airborne precautions recommended. So the airborne infection, you should put the patients in isolation room. For the healthcare personnel, use your PPEs, okay? And a certified, particularly, you have your eye protection, respiratory protection, which includes your N95 filtering piece respirator. So, standard and droplet precautions when providing care to all patients with symptoms of acute respiratory infection. Contact precautions or eye protection added when caring for probable or confirmed cases for MERS-CoV. And airborne precautions should be applied when performing aerosol generating procedures. So this has been the travel notice for MERS-CoV before. So it's more or less similar to what is happening right now. So alert level 2, again, practice enhanced precautions. Okay, so here, everyday actions that helps prevent the spread of the germs. Wash your hands with soap and water. Okay, so if not available, we have your alcohol-based hand sanitizers. The same way, avoid touching your eyes, nose, and mouth. and avoid close contact with the sick people. So be sure you are up to date with all your shots. Okay, so with your immunizations, make sure you know your immunization status. Okay, so if possible, see your healthcare provider at least 4 to 6 weeks before travel to get any additional shots. So for the responsible traveler, so if you are sick, you cover your mouth with a tissue when you cough or sneeze and throw that right away into the trash bin. Okay, so avoid contact with other people to keep from infecting them. And you must see a doctor if you develop fever and symptoms of the lower respiratory illness within 14 days after traveling from countries in or near the Arabian Peninsula in this case. So, say no to camels. People at high risk of severe disease, you take precautions when visiting farms and markets where camels are present. Okay, so avoid contact with camels, don't drink raw camel milk or camel urine, and not eating meat, the meat of the camel that has been thoroughly, even if it has not been thoroughly cooked. Okay, so here is just like tabulation, differentiating the between, I mean, from the influenza or the flu, seasonal flu, the SARS-CoV, and the MERS-CoV. Okay, so here, as you can see, SARS-CoV are both coronaviruses. Okay, and the MERS-CoV and your influenza, seasonal influenza is your influenza virus. Okay, for incubation period, the influenza is shorter at 1 to 4 days. However, in SARS and MERS-CoV, it's around 2 to 10 days or 2 to 14 days. Okay? So, transmission-wise, mainly through droplets ang influenza, and your other two with the corona infection is mainly close person to person contact. Okay. However, airborne transmission has been still been not proven or is still questionable. So the period of contagiousness is here. For influenza, it begins 1 day before the onset of symptoms and up to 5 to 7 days after becoming sick. For SARS-CoV is they are mostly contagious during the second week of the illness. However, in the MERS-CoV is not known, and this is not contagious during the incubation period. Symptoms-wise, more or less, they have the same. You have respiratory symptoms. All of them have present with fever. However, in your MERS-CoV, this more severe, the acute respiratory illness, and there's shortness of breath. It's same as your SARS, okay? And they also have like GI symptoms, the same. Um, they may have diarrhea, okay, or vomiting, okay? So more or less they are the same. Treatment-wise, for flu, you can take oseltamivir or Tamiflu. However, for your SARS and MERS-CoV, there's no known antiviral therapy, so mainly supported. Okay, so for the vaccination, yes, we do have vaccines for seasonal flu, but none for SARS and MERS-CoV. Okay, so fatality rate, it is highest in MERS-CoV at 34.8% or about 35%. Okay, so it's now time to get your shots, either pneumococcal or flu shots. Okay, so today, here between 2012 and June 30, 2018, you already have around 2,000 laboratory confirmed cases of MERS-CoV infection. 83% of whom were reported from Saudi Arabia. Okay, so there were also reports from 27 countries in the Middle East, North America, North Africa, Europe, and the United States of America and Asia. Okay, so males were more affected at beyond 60 years old. Okay, and they have underlying comorbidities like your diabetes, hypertension, and renal failure. Okay, so that's it. Here's another update. It's more or less the same figures. Okay, so what's very important is our 5 moments of hand hygiene. So first, before we go to, in contact with your patients when you are in your clinics, no? So I'm sorry for this slide. This is quite blurry. So before doing aseptic task, after touching body fluids or being exposed to body fluids, after patient contact, and after contact with patient's surroundings. Okay, so that's the hand hygiene. Okay, so how long should you do hand hygiene? It's 20 seconds or the whole happy birthday song. Okay, so I guess this is all for now. I hope you understood everything. This seems to be so familiar to all of us right now. Thank you for your kind attention and stay safe always. Goodbye.